So, good morning. So, today we are starting on to pregnancy. So, we have already discussed about contraindication in pregnancy part, and also we have discussed the preeclampsia in detail in the last video. So, now let's get into the question proper. We'll be discussing the questions right now. Okay. Okay. First thing is uh, first question, that is the pregnant women with blood vision, headache and BP is 170, what to do next? Okay, so here you can see the patient is already having some symptoms, some symptoms like blood vision. So here you can symptoms like blood vision is there for the patient here, so which means that she needs some sort of an mm, intervention right now. So she needs some kind of an intervention to be done right now. So first thing is the blood vision over here. So the blood vision and the headache, which is pointing towards the fact that she needs some intervention, so that the answer will be stabilize the patient, give magnesium sulfate and then deliver the patient. Okay, if the patient is was not having any symptoms, we can admit the patient and then give her antihypertensives and then wait till the 37 weeks answer would be right. But she is having some symptoms like blood vision and headache, which is showing that she is already having preeclampsia, and so we need to stabilize the patient, immediately give magnesium sulfate and deliver the patient. Okay, next thing is about magnesium toxicity. So here there will be a scenario where the patient is having some eclampsia symptoms and then she was given magnesium sulfate, and after that she developed some sort of an angle, it was something different. So after that you find that patient is having magnesium toxicity, so she had some respiratory issues. So after that you come into a point where you understand that she has magnesium salt toxicity. So in that case, first thing that you will be doing is to discontinue magnesium sulfate first, and only after that you will be giving calcium gluconate. So first thing will be discontinuing magnesium sulfate. What will be your first step? That will be discontinuing magnesium sulfate. Okay, next question is about preeclampsia. So next up question about preeclampsia is primary gravida, 32 weeks, came with mild headache. So you can see mild headache with no abdominal pain or visual disturbance. Blood pressure is 150/90. Urine analysis 3 plus protein, appropriate management. You can see the patient is only 32 weeks. Okay, she is not 37 weeks plus, she is just 32 weeks and only she have mild symptoms. And BP is also like 150/90. Okay, in this case we can wait for the patient to reach 37 weeks. So first thing that you can do is admit and observe, and you can wait till 37 weeks and then you can deliver the patient. Okay, here the question's answer will be this one. Next thing is pregnant, 32-week gestation with BP 150/90 and proteinuria 3 plus. What is next step? This is the same question as this one. Admit and observe. Okay. Next is pregnant, 10 weeks and hypertension. Never went to doctor before. Chronic hypertension. What is the complication? Okay. 10 weeks pregnant with hypertension. Never went to doctor before, which means before this 10 weeks means she's already having hypertension even before pregnancy. It is not related to pregnancy. Okay. Next thing is she is having chronic hypertension. She have never visited doctor. So the complication is preeclampsia. Okay, this could be a complication. So next question is pregnant patient. Is 38 weeks. Okay, so she could be delivered. Okay, next is BP is 150/90, elevated protein creatinine ratio. So okay, what could be her, like what would be her like what kind of an hypertension she is having? That is what it is asked in this question. So this is preeclampsia because it is in 38 weeks. Okay, present in 38 weeks. So before that they are not saying that she was having hypertension even before that period of time, or they are not saying that it's after like delivery. So this is not a case of chronic hypertension or gestational hypertension. This is preeclampsia. Okay, 38 weeks, because this is at 38 weeks, and elevated protein and creatine ratio is also present, so we can say that this is preeclampsia. Okay, next is 39 weeks women with proteinuria, that is BP is 190, for 140/90, your action. So proteinuria is present, and you can admit and observe the patient, but more better it is to uh, start a labor induction, because it is almost past 37 weeks. Okay, so in this case you can start you can do the labor induction and deliver the patient right now. Next is pregnant with preeclampsia, mild, 140/40 with abdominal pain, platelet and urea card. What indicate severity? So this mild eclampsia only, because it is 140/40. Maybe this is 140/90 here, with abdominal pain, platelet and urea. What indicates severity? So which one you need to give priority, abdominal pain or platelet count, or whether it is uric acid? It is the severity of abdominal pain which you need to give more importance to. Okay, now, a case of preeclampsia on labetalol. She is 32 weeks, fundal height is 28. What is commonly occur with IUGR? So, IUGR most probably in case of preeclampsia, it is due to oligohydramnios. Okay, and it is because the kidney is not much developed. Baby is not baby is not producing much of urine. So, in that case, most probable thing will be oligohydramnios, because you can see the fundal height is just 28. Okay, next is IUGR. Which one of the following can cause oligohydramnios? Okay, IUGR, what could be the cause? That is oligohydramnios may be the cause. Okay, next is two case of preeclampsia, 32 week, other cases 34 weeks, has hypertension and proteinuria management. So this is like we can admit and observe the patient till 37 weeks. 37 weeks is the cutoff, you know that. So if the patient have not yet reached 37 weeks, you can, and she doesn't having much of the symptoms, severe symptoms, so without severe features, then you can admit the patient and observe till 37 weeks and then deliver the patient. Okay, so here, admit and observe will be the answer. Delivery is only cure for preeclampsia. Patients with preeclampsia without severe features are induced after 37 weeks of gestation. Before this, the patient is usually hospitalized and monitored carefully. For the development of the worsening of preeclampsia or a complication of preeclampsia, the immature fetus is treated with expectant management with corticosteroids to accelerate lung maturity in preparation of early delivery. Okay, next thing is, okay, if the patient is having severe features that we have already discussed severe features like headache, or if she is having any kind of blood vision, then delivery should be considered after 34 weeks of gestation. In case of severity of disease, must be weighed against the risk of fetal prematurity. In case of emergency setting, control BP and seizures should be priorities. Okay, if it is in an emergency situation, you need to control her BP and seizure before going into the delivery of the baby. Okay, this is only thing that you need to take care of. So this is an important part here. You can note this if you want. That is this always gives about the timelines actually, because one is 37 weeks. 37 weeks can be considered if the patient is completely normal. Okay, if she is having only mild symptoms, then you can consider this 37 weeks thing. Okay, if she is not having severe symptoms, you can wait till 37 weeks for the delivery. But if the patient is really having some severe symptoms, it will be like 34 weeks. If she have attained 34 weeks of gestation, you can deliver the patient right away. Okay, only thing is that in emergency situation, you need to control the BP and you should give magnesium sulfate and deliver the patient. That is the only thing that you need to do. Okay, next question, it's pregnant 34 weeks with preeclampsia. Here you can see 34 weeks, and high BP is 170/100. So you can see preeclampsia is there, which means she have symptoms, and it is already 34 weeks, and also the BP is 170/100. So in this case, we have to deliver the patient right away, because she have already 34 weeks already severe symptoms, and we have 34 weeks. So your thing is, in emergency situation, what you will do, you will stabilize the patient, you will give something for her seizures, that is magnesium sulfate, prevention of seizures, magnesium sulfate, and then you will deliver the patient. This is not admission, it is actually deliver. You can deliver the patient. If she is having severe symptoms, you have to deliver the patient. If she is okay with it, that is, if she is having only mild symptoms, then you have to actually get into admit the patient and wait for 37 weeks. Okay, next is preeclampsia. What drug to give to prevent convulsions? That you have already seen, that is magnesium sulfate. Patient with 34 weeks vaginal bleeding, open cervix 6, preeclampsia, fetal bradycardia. Next step, you already know, this magnesium sulfate and delivery, because she is having the baby's like situation is like fetal bradycardia is there, and also she's 34 weeks already, and also vagina is bleeding and cervix is open at 6. So it is better to deliver the patients right away. Okay, next is 32 weeks. 32 weeks preeclampsia, what to do? In this case, you can just preeclampsia, they have not mentioned it have some severe symptoms and all, so you can wait. So here, okay, so here you can wait till the 32 weeks is achieved, and then admit and observe the patient. Okay, admit and observe the patient till 37 weeks. 37 weeks, till 37 weeks you can admit and observe the patient. Next is 34 weeks preeclampsia. Patient gives with epigastric pain, headache, blurred vision. Non-stress is reassuring, but she is having epigastric pain, which is severe. Headache is there, blurred vision is there, so she is having severe symptoms, and also she is 34 weeks, so you can deliver the patients right away. So you can give magnesium sulfate and then deliver the patient. Okay, magnesium sulfate given to hypertension, to prevent attack of eclampsia. So why is magnesium sulfate is given? It is to prevent the attack of eclampsia, which is basically to prevent the convulsions. Okay, next is pregnant. Now BP is 140/90. Okay, platelet is 90. Previously severe preeclampsia. What indication of here is about severe preeclampsia. So here it is the platelets. If there was abdominal pain might have been severe. Abdominal pain will be the thing which is showing the severity of preeclampsia, but here it is platelets, which is more important over here. Okay, platelet is the indication of severity here right now in case of preeclampsia. So we have already discussed how you need to classify that and what is the order to classify that in the previous video. You can check that out before coming here. Next is pregnant complaints of severe abdominal pain and uterine contraction. She was given 6 milligram of magnesium sulfate and contraction became normal, then decrease the dose to 4 milligram, then complaint of shortness of breath, what to do? So you can see here she was given magnesium sulfate, and after that she developed this situation like shortness of breath, which means that it is a case of magnesium sulfate toxicity. So here, you first thing that you will do is stopping the magnesium sulfate and giving calcium gluconate. So here, first step, what if it is asked first step, it will be magnesium sulfate. What is the most appropriate management will be stopping magnesium sulfate and giving calcium gluconate. Case of preeclampsia with very low platelet and high urea, what indication is that is preeclampsia? So case of preeclampsia with very low platelet and high urea, what indicators is that is preeclampsia? Okay, you can see here there is very low platelet, so the platelet gets more priority than the high urea level, so low platelet will be the answer over here. Next is, if there was abdominal pain, that would get more priority. Okay, next is pregnant with seizures and takes 6 milligram of magnesium sulfate, then decreased to 4. There is absent deep tendon reflexes. So absent deep tendon reflexes shows this case of magnesium sulfate toxicity. So here, first thing is to stop magnesium sulfate and then give calcium gluconate. Whatever comes, if this is a two different options, that is, if magnesium sulfate is given and also calcium gluconate option is given, first preference always goes to magnesium sulfate, stopping magnesium sulfate. Okay, and only after that you can go to give the answer like calcium gluconate. Okay, Next thing is patient is on oxytocin and magnesium sulfate preeclampsia. Her CTG shows absent variability. What is the cause? So any changes in the baby's activity also moves into the direction of magnesium toxicity, so that is causing the problem in the baby. Okay, mother with preeclampsia was given oxytocin and magnesium sulfate, and now CTG of the child is non-reactive. Again the same question, so you can see that. Sorry. Next is patient is at 32 weeks and presented with seizures and high blood pressure. So what is the next appropriate thing that you need to know? There is no medication for seizure. So here you can see seizures with high blood pressure, and what is the appropriate thing that you need to know? There is no medication for seizure. So the patient has already developed seizures and high blood pressure. First thing that you need to do is give magnesium sulfate, and only after that you have to think about other answers. Okay, why administering magnesium sulfate in case of preeclampsia? Already discussed, is to prevent convulsions. Okay, well, severe preeclampsia, acute management of hypertension drug. Okay, severe preeclampsia, acute management of hypertension drug is hydralazine. Okay, hydralazine is the drug of choice in case of severe preeclampsia. That we have already discussed. You can go back and see the last video. Next is GDM type F with nephritis and controlled hypertension. She is pregnant now. What is the most complication will occur? It's preeclampsia, because you can see here nephritis is present, and also she is having uncontrolled hypertension, controlled hypertension. But whatever it is, if she is having hypertension even before pregnancy, there is chance that she may develop preeclampsia. Next is pathology of GDM. So GDM is something that is coming in a different topic, but still it is here. It is placental hormones, which is lactogen, which is the problem. Okay, lactogen is the problem. Okay, we have already discussed the complete topic in the last video. Please do check out that before coming here. It's just better if you have already gone through that topic. It will become more easy when you come back here and listen to this one. So better go back and hear that video and make notes out of it. Already we have explained it very well in the last video. We have took almost 28 minutes to explain this area. This is very important, and there is a lot of repeated question coming from this area. Okay, next we will discuss about the first 1 week, what are the things that we look to, and what are the things that we need to look into. So till then, it's bye, and next video we will discuss about the first week and what are the things that you need to look in the first week of pregnancy. Thank you so much.